Hi guys, welcome to Radiology 365, where we try to cover core radiology from cover to cover. Today we're going to be talking about vascular liver diseases. Now, I may not be able to show images for all these cases, but I do hope that the theory would put our minds in the right space. Start off with Budd-Chiari syndrome. What is it? Budd-Chiari is a condition where the hepatic veins get blocked, preventing blood from draining properly out of the liver. This blockage can be due to a clot or non-thrombotic causes. Most of the time, the thrombotic type is linked to things that make the blood more likely to clot, like blood disorders, pregnancy, oral contraceptive use, cancer, where you have tumor thrombi, etc., infections, or even trauma. Rarely, it can be caused by a congenital issue with the hepatic veins, like maybe a congenital web, but that's super uncommon. When Budd-Chiari shows up suddenly, you'll typically see the classic triad of hepatomegaly, fluid in the abdomen, that's ascites, and abdominal pain. On imaging, key things to look out for include absent blood flow in the hepatic veins. That's obviously because there's an obstruction in the hepatic veins, and so there wouldn't be flow. You could also look out for a visible thrombus or something obstructing the hepatic veins, like a web, or even in the IVC, and development of collateral vessels that can look like spider webs when you do a venogram. So this image is a selective venogram of the hepatic vein. This one, the right hepatic vein, was cannulated and contrast injected into it, and we can see this spider web pattern of collaterals emanating from it. In the acute phase, the liver looks swollen and mottled. That's what we call the nutmeg liver. But also the caudate lobe is often spared because it drains directly into the IVC. A fun imaging sign is the flip-flop enhancement pattern, where the center enhances first and then the peripheries enhance later. And when the peripheries actually do enhance, the center loses its contrast. So kind of you flip the contrast enhancement. That's what they call flip-flop. When it becomes chronic, the liver may start failing. The caudate lobe would grow bigger and the rest of the liver would start to shrink. You might also see regenerative nodules popping up, basically signs of chronic liver disease. It's not necessarily specific to Budd-Chiari, but when Budd-Chiari persists for very long into the chronic stages, you basically have the liver looking like a chronic liver disease case, regardless of the cause. So this image actually shows focal narrowing or wasting of the intrahepatic inferior vena cava with a linear filling defect. You can see that here. Then there's also hepatomegaly and heterogeneous enhancement of the liver, making it look like the inside of a nutmeg. And also, here the hepatic veins are not really visible, but we can tell that the cause of this syndrome is IVC and not hepatic vein related. There's also splenomegaly, and you can see some ascites all around in the peritoneal cavity. Then to veno-occlusive disease. Veno-occlusive disease is a bit different from Budd-Chiari, although they are both kind of obstructive diseases of the veins. However, here in veno-occlusive disease, it affects the small hepatic vessels. Toxic injury to the liver sinusoids would cause sloughing of the endothelial cells, and then these endothelial cells will now go and embolize the hepatic venules. That's the tiny venules that eventually drain into the hepatic veins, and these would cause eventual fibrosis of the venules, and this result in hepatic congestion, similar to Budd-Chiari syndrome, just a little more downstream. And also you would have post-sinusoidal portal hypertension as a result, which makes sense. In the early stages, you might notice swelling around the portal triad because of the congestion. Then the hepatic veins themselves will be narrowed because there's very little blood draining into them anyway, so they're not going to be engorged as you might have seen if you had Budd-Chiari. And you would also have an enlarged liver. Also, you would have patchy contrast uptake. You would have ascites, similar to Budd-Chiari. And the gallbladder wall would also be thickened, all related to the subsequent congestion and edema that occurs downstream. Unlike Budd-Chiari, the caudate lobe isn't spared. As veno-occlusive disease progresses, the liver can start to resemble cirrhosis again, as it stays for long. The liver, chronic liver disease, its appearance is still the same. If you are evaluating a post-transplant patient and you are unsure whether it's veno-occlusive disease or graft versus host disease, here's a clue. If the right hepatic vein is small, less than 0.45, like I said, it's likely pointing more towards veno-occlusive disease. But then if you have small bowel wall thickening, then graft versus host disease is more likely. Now to Peliosis Hepatis. Peliosis is pretty rare. It's a benign condition where blood-filled spaces called lacunae form within the liver. Sometimes there is no clear cause, but it's been linked to medications like steroids and oral contraceptives. Immune-related conditions like HIV or infections like TB and Bartonella have also been implicated. On CT and MRI, these lacunae or lesions tend to enhance centrally first. So it's as if you have dug a pit and you have a pipe pouring contrast into that pit. It will fill the center first, and then as it fills up the peripheries, then starts to also pick up the contrast. So unlike in hepatic cavernous hemangiomas, which would fill peripherally nodularly and then eventually have centripetal flow towards the center, for Peliosis you rather usually have central filling first and then eventually have a centrifugal kind of enhancement. Although rarely you might also see some centripetal filling, but that's not a classic behavior. On ultrasound, they might just look like a bright non-specific mass. Now to cardiac hepatopathy, this one's all about the heart affecting the liver. When the right side of the heart struggles due to heart failure, valve disease, constrictive pericarditis, or heart surgery, blood backs up into the liver, causing passive congestion in the liver. Over time, this can then lead to cardiac cirrhosis, and then the imaging features of chronic liver disease would manifest as we have come to know them. On imaging, it will be important to look for enlarged hepatic veins and IVC with contrast refluxing backward from the right atrium. The liver is usually enlarged and shows a mottled nutmeg appearance similar to Budd-Chiari and whatever congestive condition there is. Ascites is also often present as well. So to wrap up, Budd-Chiari is a hepatic vein obstruction with caudate sparing. Veno-occlusive disease involves the small vessels, small venules, usually after stem cell transplant, and doesn't spare the caudate. Peliosis is a rare condition and involves blood-filled cavities. Cardiac hepatopathy is liver congestion from right heart issues, which also gives the nutmeg liver look. Thank you very much for your attention. The next thing we'll talk about is hepatic Doppler. I hope so far you are finding value. If you are, give it a like, share to someone you think might need this, and subscribe if you've not subscribed yet. I will see you in the next one.